Top Bed Talk.
Good afternoon, good morning to you from wherever you're joining us from. Thank you so much for joining us for EBPOM Ireland, the session 1.4, Novel Therapies in Perioperative Care. I am your co-chair, Desiree Chappell. I'm a CRNA from Kentucky and Vice President of Clinical Quality for NorthStar Anesthesia and Managing Editor for Top Med Talk, so have a couple different hats here. And I'm joined by my co-chair, Ms. Vicki Morton. She's an advanced practice nurse practitioner and Director of Clinical Quality Outcomes for Providence Anesthesia in Charlotte. Vicki, thank you so much for joining us.
Thank you for having me. It's so nice to be here.
It is. So our session is about novel therapies and kind of really asking the question, why do we want to adopt these and what's important about them going forward? And so with our first guest, I'd love to bring in Professor Rob Sneyd. He is from Cornwall. And Professor, thank you so much for joining us.
Thank you, Desiree, and welcome to everybody in this session.
We will bring our other guests in kind of as we go along, but I would love to start with you. First, Rob, for everyone watching today, tell us just a little bit more about yourself. You've done a lot of work in your career.
I've been the Dean of the Medical and Dental Schools in Plymouth, and I've a career-long interest in clinical pharmacology right back to the 1980s when I worked in industry for a while. Went back to an academic interest ever since, and I'm passionate about helping industry produce things that are useful for physicians and safe for patients.
I'm going to go ahead and hand it over to you. I know you have a short presentation, and then we'll come back and ask some questions.
Thank you, Desiree. These are my interests. Altus are a Canadian company who make technologies for dissolving stuff like anesthetic drugs. Pion make remimazolam, and Medtronic make capnographs. So a lot of what I'm going to say is in this review article, which we wrote for the British Journal of Anesthesia in the summer of this year. And there's a lot of stuff about the whole perioperative period and all of the drugs. And in this presentation, I'm focusing really almost entirely on benzodiazepines and remimazolam. So last year, Dan Sessler from the Cleveland Clinic wrote that hypertension during and shortly after induction results from anesthetic drugs is presumably largely preventable. So a big focus on hypertension that you're going to feel palpably through the whole of the perioperative medicine discussion. And there's the obvious stuff about not letting all the blood out, getting the fluids right, thinking about your epidural, not giving too much anesthetic. I put my favorite surgery, which is a finger operation under tourniquet, which is about the only one in which I can be really confident the surgeon isn't going to let all the blood out. So what about benzodiazepines, both in surgery and in sedation? In the 1960s, Diazepam was a white powder that wouldn't dissolve in water. It forms a mucky, sludgy solution. It hurts when you inject it. But if you look at this slide inside the green box on the top left, the arterial blood pressure, which is the major trace, doesn't change on induction of anesthesia. So you can induce an anesthetic state with the benzodiazepine, Diazepam, with really no effect on the blood pressure. That was fine, but it's a drug that hurts and is very slow to recover. Jim Reeves, a decade later, reported on Midazolam, which is now water-soluble, has a dose-response relationship. You give it more of it, you get a bigger effect. Great cardiovascular stability. At that point, they felt that Midazolam was a promising anesthetic induction agent for further study in man. John Dundee, legendary Belfast professor of anesthesiology, insight into clinical pharmacology of those days. You could have Midazolam in the morning and do a full day's work in the afternoon. But they also pointed out the lack of cardiovascular toxicity, which was a good thing. But there was great individual variability, which made it really not very useful as an induction agent. So the question, can we use benzodiazepines to induce anesthesia? The answer is yes. Is it useful? Well, that's questionable. Here is a small study comparing propofol anesthesia with alfentanil versus midazolam and midazolam with flumazenil reversal. You can see that use of midazolam as a maintenance agent produces a consistently higher blood pressure during both induction and maintenance of anesthesia. However, if you look at the time to open the eyes, the propofol patients open their eyes in 4 minutes. Midazolam is 36 minutes. And even when you give them flumazenil, it still takes 10 minutes. So really not useful. Brings us to remimazolam, which was a spin-off from the Glaxo Wellcome project that led to remifentanil. It's had a very slow development, but it's broken down by the same tissue esterases that tackle remifentanil. Last year in Japan, where it's now been licensed for induction and maintenance of anesthesia, this is a big phase 3 study comparing two groups induced with remimazolam and another group induced with propofol, all the patients getting some opioid. Loss of consciousness, 78 seconds for the propofol patients and a few seconds longer for remimazolam. So it produces a useful induction of anesthesia. Is the bispectral index going down? You can see maybe the propofol patients are very slightly deeper. If you look at the adverse events coming out of that study, there are a lot more adverse events to do with hemodynamics, particularly hypotension, in the propofol patients. If we go to the other end, the eye opening was slower in the remimazolam patients than those given propofol. So that begs the question then, might remimazolam be useful as an induction agent? There have been a couple of studies. Here's one published this month from Japan, looking at the hemodynamics of patients having valve replacements. The mean arterial pressure was better maintained in the propofol patients than in the remimazolams, and then there was more hypotension and more adrenaline required, norepinephrine required in the patients given propofol. This is a Kaplan-Meier plot of patients going off to sleep. So at the top left-hand corner, everybody's awake. At the bottom right, everybody's asleep. At the time is about 2.5 minutes. And the two lines there superimposed are elderly and normal age patients, and there's no difference in rate of induction in the elderly. And these are thin, medium, and fat patients, and the obese are fractionally quicker to go to sleep. The major European phase 3 study hasn't been published yet. For regulatory reasons, the manufacturers put out a press release telling us that remimazolam was non-inferior to propofol as an induction and maintenance agent with superior blood pressure control. So I think we can look at that in the context of knowing that perioperative hypertension is really bad. I pointed out to you the Dan Sessler paper. Here's one from the BJA a couple of years ago suggesting an organ injury threshold of about 10 minutes with a mean arterial pressure of about 80. Interesting question of whether hypertensive patients who get into trouble are, if you like, the dead man walking out of the Green Mile. They maybe are already destined because of comorbidities. What about sedation? Here are unpublished data that we're working on of 400 patients with propofol sedation. The zero line is their baseline, and you can see that most of the blood pressures are going down with a small number going up. And in the red box, you can see patients undergoing propofol sedation for colonoscopy experiencing episodes of hypotension whose duration and depth is approximately the same as those that we know to cause organ injury in operative surgery. What about onset and offset? Just a little pharmacology reminder: if we give a bolus of propofol, the concentration goes up and it comes down. The drug effect goes on and it comes off a little bit later. And there's the hysteresis gap between the peak effect in the blood and in the brain. If we apply that to opioid pharmacology, here's a little bit of history from fentanyl through alfentanil and remifentanil. The peak effect of fentanyl is about 4 minutes, alfentanil, remifentanil about 1 minute. So progress in anesthetic pharmacology is quicker onset and quicker offset. Here's 3 hypnotics. This time, midazolam, the brown dashed line, remimazolam, the black one, and propofol, the green dots. And there's progress in benzodiazepine pharmacology, with remimazolam having a quicker onset and a slower and a quicker offset. So what can we say about remimazolam? We can say that it has an onset that is much faster than that of midazolam, but it's not as quick as propofol. It has an offset much faster than midazolam, but it's slower than propofol. And I think when we're talking amongst ourselves and with our residents, it's important that we don't just call it Remi, because people are going to get confused with remifentanil. And the opioid remifentanil has a quicker offset than remimazolam, the benzodiazepine. I just spotted a type in my green box there. So if we compare propofol and the benzodiazepines, we know that propofol has fast onset, great recovery, but it causes hypertension, needs airway skills, and the patients can get into trouble if the airway's been lost. The benzodiazepines are slow, are safe, the blood pressure is well maintained, they're easy to use. And that's reflected in the mission. So looking ahead with remimazolam, where we are at the moment, on the right with sedation, it has less hypotension, doesn't need an anesthetist, blood pressure is well maintained, airway is maintained, it's easy to use. And conceivably, there might be a development in due course to consider ICU sedation if that's experimental. On the left, anesthesia, which is not licensed in Europe, it's not licensed in the United States. It is licensed in Japan and China and Korea and a number of other countries, where there is rapid onset and recovery. There's satisfactory and hemodynamically stable maintenance of blood pressure. If we think about our clinical colleagues, our sedationist colleagues, and our proceduralists, as anesthetists, you are experts of pharmacology, you understand PK/PD, you've got great airway and resuscitation skills, and you default to using propofol. We have persuaded our surgical and radiological colleagues to focus on drugs that they understand. They're focused on the procedure, their pharmacology is patchy, they don't understand PK/PD, they've got pretty variable resus skills, and they've, with our guidance, defaulted to midazolam and fentanyl. And benzodiazepines are logically a safe place for them to be, rather than messing about with propofol. So I'll finish by saying that remimazolam is an interesting addition to the perioperative armory. I'm sure it's going to be useful for non-anesthetists in sedation, and it may become helpful as an induction agent if further work has been done to tackle some of those patients who particularly our US colleagues might currently consider giving etomidate to. Thank you.
All right, Rob, thank you so much for that presentation. So let's contextualize this just a little bit, because people listening from all over the world, you know, when we talk about sedation, because that's, you know, one of the pieces, sedation versus anesthesia, you know, traditionally it's like narcotics and an anxiolytic delivered by a nurse, at least in the US, what I'm familiar with as well. And then when we look at sedation for an anesthesia provider, we're usually using propofol. Is that what it's like kind of around the world, or does it look different in many different places?
I think that's globally true. The volume of propofol sedation that's given is often a function of the reimbursement environment, where people in private practice are more attracted to anesthesiologists with quicker throughput, more hands-on, better patient experience. I think what is important is that our clinical colleagues have mostly focused themselves safely around benzodiazepines and adjunct use of small doses, preferably a single dose of fentanyl. Non-anesthesiologist use of propofol is practiced, not in the US where it's pretty much prohibited, but it is practiced safely in places like Germany on the basis of very small doses of propofol given very carefully and rather slowly against a really tight protocol by well-trained nursing staff. And I do stress that. So it's not a free-for-all. I think that nurses and specialist sedationists who've had supportive training and have demonstrated their competencies can use low-dose propofol, sticking to a protocol.
I think that's a big point that you just made, you know, well-qualified individuals. And I know for us in our institutions, you know, that's sometimes a challenge when we're doing procedures, what have you, or even in, let's just take, for instance, office-based type anesthesia. You know, we're moving a lot towards that in certain procedures. And there aren't necessarily the qualified practitioners that are there providing the sedation, not as qualified as they should be.
There's only one set of standards, which is a high standard. There's only one set of interests, which are the patient's interests, and there's only one form of acceptable practice, which is safe practice.
Absolutely.
And I think when people are launching into adventures in unusual environments, they should look really profoundly at themselves in the mirror and say, if this all went badly, how am I going to explain what I chose to do today? And defaulting to safe medicines, particularly benzodiazepines, particularly just one dose, for our colleagues, for most of them, is the right thing to do. And I think that remimazolam may be useful to them because they can get a little bit more of the quicker onset, quicker offset that they enjoy with support with propofol, but without getting into the same difficulties with airway control.
We talk about the safety profile of meds, especially whenever we're adopting new therapies. And I can tell you, whenever we are, you know, in the conscious sedation space and that versus anesthesia, we sometimes have to go in and kind of help stabilize airways and do things like that. What is the safety profile, and do you think that's really what is going to be distinguishing this particular novel therapy?
Well, from the limited data that's available, I think that pharmacodynamically, remimazolam and benzodiazepine basically have the same effect. If I gave you two patients, identical twins, one sedated with each, you frankly couldn't tell the difference from looking at either the patient or the monitor. The difference would be how long they'd taken to get to that state and how long they took to recover from it. So it's all about the dynamic component, the onset and the offset, which is what I've tried to show with those simulations, which people can look up in the review article.
That's great. Okay, first question here. Has remimazolam been studied in providing brief, deep sedation for procedural sedation via possibly nerve blocks as a way to avoid respiratory issues?
There's very limited data, so that the regulatory studies, the phase 3 studies, are bronchoscopy and colonoscopy. Japan is the place that's generating case reports because it's got the most profound uptake in the market there. And if you just go to PubMed and stick in the word remimazolam, you'll get a fair selection of small reports coming through of everything you can possibly imagine. There was one that literally came through today of a 96-year-old and another 105-year-old having general anesthesia for fractured neck of femur with very favorable hemodynamic response. So that is, if you like, is learned experience being reported as case reports, as opposed to regulatory studies which tend to focus on high volume things, hence the bronchoscopies and the colonoscopies.
Yeah. So where do you see sedation going in the next 5 to 10 years? I mean, is this going to be kind of a standard practice to use medications like this, or do you think it's going to take a while and we're all going to stick with propofol?
I think anesthesiologists have to get over it. We have got a huge clinical community to serve. We've got tremendous numbers of great colleagues and needy patients, and we haven't got enough anesthesiologists, and society cannot afford to pay an anesthesiologist to give 5 milliliters of propofol to an ASA1 patient having a colonoscopy. It's ridiculous. That is not a consultant anesthesiology occupation. And we should be empowering and supporting our colleagues with great training and safe pharmaceuticals to tackle, shall we say, the hump of these things, and then we can concentrate on the anesthesia nightmares that they will serve up probably at 5 o'clock on a Friday afternoon.
Professor Sneyd, Rob, thank you so much for joining us and giving that wonderful presentation. Stick around, because at the end we will come back and have just a quick little chat before we head out. So to our next novel therapy, we are going to be talking about novel post-operative rescue antiemetics. And joining us today, we have Drew Riddle, who is a CRNA from Texas. He is faculty at Texas Christian University. Drew, thank you so much for joining us.
Hi, thanks so much for the invitation. It's a pleasure to be here.
It is.
Happy to have you.
Drew, you are a fellow CRNA. Just really quickly, give us a little bit about your background about being a CRNA and the roles, because I think I said faculty instead of associate professor. Excuse me.
Right, thanks. So I am a nurse anesthetist. I've been in anesthesia practice for 20 years, and I have a fair amount of international experience with anesthesia, specifically in Australia and some in Taiwan and mainland China. And so the role of the Certified Registered Nurse Anesthetist, or CRNA, in the United States is a bit different than other non-physician anesthesia providers elsewhere in the world. And so in many countries, there are individuals that are not physicians that provide anesthesia. And in the United States, we have a category called Certified Registered Nurse Anesthetist. And it is a 3-year postgraduate doctoral training program with both didactic and clinical residency or clinical training experiences that culminates ultimately into the ability to sit for a certifying exam. So 100% of us in the United States are board certified to provide anesthesia, and CRNAs in the U.S. work all facets of anesthesia delivery, from small rural facilities, ambulatory surgery centers, large academic and community hospitals. It's a fantastic practice, and a model that, quite frankly, has been looked to have been replicated worldwide, and other countries are moving in that direction. We work alongside our physician anesthesiologist colleagues in many practices, both CRNAs and physician anesthesiologists, or anesthetists for those of you elsewhere in the world, work hand in hand to provide anesthesia care.
Today we're going to be talking about some new rescue antiemetic medications, and the question was, do we need a new antiemetic? And I know you have a little bit of background in this space. So tell us, first of all, we have Zofran. That kind of seems to be it, but we clearly know it's not working. So talk to us a little bit about some of these new therapies.
Unfortunately, unlike Rob, who just spoke about sexy things like sedation, post-operative nausea and vomiting is no fun. It's no fun for the anesthesia folks. It's no fun for the surgeons. And of course, it's absolutely no fun for our patients. And, in the 20 years I've been doing anesthesia, I think, oh my gosh, if I hear one more talk or listen or read one more paper about nausea and vomiting, I myself am going to have nausea and vomiting. But the reality is, we haven't conquered it completely. And, often post-op nausea and vomiting gets lumped in with other types of nausea and vomiting, chemotherapy-induced nausea and vomiting, other drug-induced nausea and vomiting. And the reality is it is a bit of a different phenomenon. We've done my research world is in genetics and pharmacogenetics, specifically looking at molecular genetics of nausea and vomiting and how we perhaps can predict or plan therapeutics based on a patient's genetic profile. And so what we know, to answer your question, is despite excellent prophylaxis that's evidence-based, based on risk stratification for our patients, we still end up with a between 20 and 35% failure rate, meaning we did everything appropriately to try to prevent the nausea and vomiting in the patient. The dexamethasone, the ondansetron, the IV fluids, perhaps a transdermal scopolamine patch, and elsewhere in the world there are other drugs that are available and useful. The problem is once those patients fail the prophylaxis, what do we do to treat them? And really the data there is quite scattered and really not robust. And so into the world of a novel therapy, actually it's a new formulation of an old drug that's being used now, and it is approved for use in the US.
It's called Barhemsys, right?
Yep, Barhemsys. That's the trade name here in the United States. Acacia Pharma is the name of the pharmaceutical company that manufactures the drug. Acacia is actually based in the UK, and it is approved in the US. Amisulpride is the generic name of the drug. And actually, amisulpride is a drug that our colleagues in the UK and elsewhere in the EU are probably familiar with, having been given orally for decades, actually as an antipsychotic. And so,
I'm sorry, I just wanted to clarify that for 1 second. At much higher doses, though.
At crazy high doses relative to what we're giving in the postoperative. When you think about the need for this, the clinical picture, we try to relate this back to something clinical. The clinical picture is the patient who is, had an outpatient surgical procedure, perhaps in a hospital or in a ambulatory surgery center. He or she had a phenomenal anesthetic, uneventful surgery. They get to the postoperative recovery room area, and as they begin to sort of emerge and get their head straightened back on, they realize that they have nausea and they have vomiting, and that delays the discharge for that patient, whether it's to home or off to the ward or to the floor where they're going to be cared for. And as of right now, we have really clear clinical practice guidelines that suggest we should not be re-administering a class of drug that the patient already received. So if I used ondansetron, for example, as a prophylactic, the data are very clear that more ondansetron is not the answer in that patient. They've received the ondansetron, they've not had the clinical response we need. We need to go to the next class or a different class of drug. And so knowing that we shouldn't be repeating the same thing that didn't work well to begin with, we need to think about a new class. And so this is a dopamine 2, dopamine 3 antagonist. The difference in this, and something that many of us are familiar with, anapsine or droperidol, which is also a dopamine antagonist, is the affinity for those dopamine receptors and the structure, the molecular structure of amisulpride or Barhemsys, so that it doesn't cross the blood-brain barrier to the point where it causes the side effects we typically see, like extrapyramidal side effects, sedation, et cetera.
Yeah, one question whenever we talk about new drugs is, again, I said this to Rob, was the safety profile. I know that, ibifenegrin, which is one that has been on the list.
It's a long time. Terrible side effects.
Terrible side effects. So can you speak directly to the safety profile of this?
Sure. Yeah. So every drug has its risk and benefit, right? And so the safety profile, and I can tell you what it looks like clinically, having used the drug myself or administered this drug myself several times, and that is the only contraindication to the drug is a patient who has hypersensitivity to the active ingredient, to amisulpride. Usually when you look at contraindications to drugs, it's a mile long, right? And there's 15 things or 20 things we have to consider, and that's not the case here. And so the safety profile is phenomenal. The adverse event rate between, you look up the studies, the adverse event rate between placebo and active drug is the same, and those adverse events are quite low. And so in both groups. And so it really has a very strong safety profile. What it looks like clinically is this: the patient emerges from their anesthetic, they get to the recovery room, they sort of start realizing, oh my gosh, I don't feel well, I have nausea, or they actively are vomiting. They get a dose of Barhemsys IV, and within a minute or two, they say, gosh, I feel great. Can I go home? Now, let's compare that to the IV promethazine or the IV compazine or iron compazine, or perhaps the IV dose of a low dose of droperidol or anapsine. They say, gosh, my nausea and vomiting is so much better. Thank you. As they pass back out for the next 2.5, 3 hours. And having been an ICU nurse myself, look, a dose of Phenergan will get you through a really difficult night shift on a very combative patient on a ventilator fighting their sedation. And we sometimes exploit the side effects of those drugs in order to accomplish something else. But in the perioperative world, where it's all about throughput, and Rob spoke to this a bit ago with remimazolam, the notion that I can use a drug to give me clinical efficacy without the side effect profile that we typically see with other drugs that are useful for rescue from nausea and vomiting is phenomenal. So it makes it sound like we're not doing a great job. And overall, international data, U.S. specific data in the state of Texas, looking at our data here in the United States, we're doing a nice job prophylaxing our patients. Not everyone is going to need this, but when you get appropriate prophylaxis and the patient ends up with some of that nausea and vomiting and you go, oh my gosh, what do I do? How do I take care of this patient? Now we have another option. So it's really as boring as nausea and vomiting postoperatively is, it is really an exciting opportunity now to perhaps treat these patients in a way that we can get them feeling better and get them out the door.
And we talk about postoperative nausea, vomiting, right? We're really just looking at the PACU time frame, and we don't really think beyond that a whole lot. And so PDNV, post-discharge nausea, vomiting, a lot of places don't even follow that, and people don't know what that rate is. And I think it's really fascinating, and I think that we need to be paying attention to that a little bit more. And this does have a clinical utility in those areas, especially for surgeries like bariatrics, colorectal, big surgeries. This is very important for that time frame, because if the patients are nauseous and vomiting, they're not eating, they're not walking, they're not living a dream.
Absolutely.
That's right.
So we need to think about it for that phase of care as well.
The disease state, if you want to think of it that way, that is defined as postoperative nausea and vomiting, is defined as nausea and vomiting within the first 24 hours post-surgery, which we tend to think, well, as soon as they leave the recovery room or they leave the unit over which I have some responsibility in anesthesia, they must be perfect because I'm not hearing about it. And to your point, the reality is they're not, right? They're going to the ward, they're going to the ICU, they're going home. And so what are we able to do? How do we take care of those patients and help prevent it? So the data look at 24-hour complete response for this drug. So you do have a complete response for 24 hours. So one dose can give you some pretty long-lasting effects, especially to get them over that first 24-hour hump when at that point, as they're ambulating more, as they're eating a little better, as they're hydrated again, perhaps that nausea and vomiting rate is a bit lower on post-op day 2 or 3 or beyond.
So I have a question for you. We're talking about it right now as a rescue antiemetic, but, perhaps this can be used also as a prophylaxis. It was studied in both realms. So let's say now we've given barhemsys prophylactically, prior to surgery or during surgery, and 6 hours later, 8 hours later, the patient experiences nausea, vomiting. Can they be redosed?
Well, it's a good question. The official answer is those data really that it wasn't studied in that capacity, and so can it be redosed? It can. Do we have really good outcomes data to suggest that that's useful? Not really, not yet. The guidelines for treating patients that have breakthrough post-operative nausea and vomiting say that in the first 6 hours post-op, if they've received a class of drug, they should not get another class. So if I were to choose to use this drug as a prophylactic, as an antiemetic prophylactic, they wake up, an hour and a half, 2 hours later, and they have nausea and vomiting, it's likely that the dopamine antagonist is not a good choice for that patient, and they should receive a different class of drug. Now, 10, 12, 14 hours later, they're on the floor, they're in the ICU, they've gone home. Perhaps that's the time to repeat the dose. So, going back to ondansetron, right? We send a lot of patients home with orally dissolving ondansetron, at least in the US, where they put the little dissolving pill under their tongue or on top of their tongue and tend to have pretty good efficacy. We wouldn't do that in the first 6 hours post-op.
Yeah, well, Drew, one more question. We do have a question from Mark Koch, and I want to get to that. But just very, very quickly, when we talk about change in practice, utilizing and adopting new medications, new therapies, new monitoring equipment, and we always have to come up with the value proposition. Just, quickly, if we had the elevator pitch of this for a PT committee, what would that be if we really wanted to try it?
The first is we have postoperative nausea and vomiting that needs to be rescued. We have to acknowledge that we are doing a good job, but not a perfect job. The second piece is right now, the availability of rescue drugs have really sedating side effects. And this option gives us good clinical efficacy. And the data suggests anywhere between 30 minutes and about 95 minutes of PACU time saved. With one dose of Barimsus, the nausea and the vomiting is taken care of, and the patient is actually, the throughput is improved, right? So they get out the door, they get on to wherever they're going. And so I guess that's the elevator speech. But the key is we have to admit we are not getting 100% efficacy in preventing our nausea vomiting. Yeah, as hard as that is to admit.
It is. But I also asked the question, and I know we need to get to Mark Hutch's question, but how many centers actually know their rate of PONV? Who is actually following that? And I would argue that a lot of centers do not know that rate of PONV and PDNV.
It's hard to get to because it's it's not really asking the question in your EMR or wherever. It's like, are you nauseated? Right. It's, did you receive an antiemetic?
Right.
Right. Right. And so that question is exactly right, Desiree. It's not something that's typically tracked. We are able to track it in a lot of centers by surrogates, right? Yes. Well, if they got an antiemetic in the recovery room, they must have had nausea and vomiting. Well, maybe not, right? Maybe that nausea, that antiemetic was used to sedate them again because they're being a little crazy.
True.
Yet,
that's a very good point.
We say, oh, well, that's the PONV rate.
Well, quickly for Mark's question. So thank you very much, Desiree, Monty, Vicki, Drew. Awesome conference. Of course, Mark, thank you. I'm so glad that you're watching. Drew, I'm wondering if you could briefly share an overview of other countries that use CRNAs.
Great question. The role is being used is either used or being developed in other countries. And so we have colleagues in Taiwan. There's about 6,500 nurse anesthetists in Taiwan that function in a very similar role to those of us here in the United States. Finland, France, Spain, many of our South American countries are all using nurse anesthetists in some capacity. But to make sure we're clear, there are nurses who are delivering aspects of anesthesia, and then there are sort of the role of the CRNA in the U.S., which is really a full service anesthesia provider working with or perhaps without a physician anesthesiologist involvement. And so in other countries, what that looks like from a practice model could be quite different. And the training is quite varied, from something as small as an on-the-job training to a really formal programmer process. So the International Federation of Nurse Anesthetists, IFNA, is a phenomenal resource if you're interested in the international work of nurse anesthetists. And it's certainly ifna.org, and you can get a whole list, and it really breaks it down by country on what is the role of the nurse providing anesthesia in the various countries.
Well, we're going to bring Jeff in just 1 second. Last question very quickly. Is there a difference in dosing strategy when comparing prophylaxis versus rescue use, or 5 milligrams for all?
Yeah, there is. So the recommended dose and the approved dose in the U.S. is 5 milligrams IV for prophylaxis, or 10 milligrams IV for treatment. So there is or for rescue treatment rather. So if you're using this drug as part of your antiemetic prophylaxis, it's only 5 milligrams, 10 if you're going to rescue someone who has that nausea and vomiting, breakthrough nausea and vomiting and needs that rescue.
Drew, thank you so much
thank you,
for
Drew.
that. Please stick around. We can answer a couple more questions at the end. So I'm going to let Vicki introduce our next guest.
Jeff Gadsden. Dr. Gadsden is an associate professor at Duke University School of Medicine. He's chief of division of orthopedic, plastic, and regional anesthesiology.
Yeah, thanks. Well, thanks so much for having me. And it's great to be here. I need to get to Dingle next year in person.
Absolutely.
So yeah, thanks. I'm an anesthesiologist, and I do a lot of regional anesthesiology in my day-to-day job. My clinical and research interest is in keeping people comfortable and getting the maximum value out of regional anesthesia and nerve block techniques that we can, and providing all those goals of ERAS, like decreased length of stay, reduce opioid consumption and side effects from opioids, and of course, making patients feel better and recover faster.
Yeah, Jeff, we know in the anesthesia research and in the last 5 to 10 years, there's definitely been an increase in use in regional anesthesia techniques. So can you just tell us a little bit more about kind of the journey of that and kind of where we are currently?
Yeah, it's been amazing. I trained, oh gosh, seems like a long time ago. I'm not going to say one exactly, but It was before ultrasound guided nerve blocks. So just when they were about to come out, I just missed it. And it was a time when if you were a regionalist, you were considered a wizard. You had these skills that were very hard to teach and learn, and you had this extraordinary knowledge of anatomy. And ultrasound has changed everything. So now, with the right brief training, you can do anything that anyone could do in the past. And ultrasound has opened up new ways to use local anesthetics and new places to put them to keep patients comfortable and importantly avoid some of the side effects that we used to have to deal with the past. So I agree, it's really exploded, and what my practice looks like today is a lot different than 10 years ago. So in a given day, I'm running around to ORs to do fascial plane blocks for GU surgery, for GI surgery, for spine surgery, for cardiac surgery. And 10 years ago, I was just doing orthopedic surgery. So
yeah, that's what I was gonna say. It looks different. You had the, twitch monitor and putting the local right there around it. Now we're doing all these different, fascial plane blocks. You mentioned that, like tap blocks, but now there's ESBs. So the erector spinae block as well as the quadrantulum. Yeah. So, that's all stuff that you're doing these days, right?
A whole alphabet soup, QL, ESB.
Yeah, it is.
Everything has to have a cool acronym.
That's right. Well, Jeff, I think that we can all agree in the anesthesia space, especially in the U.S., because we've been talking about this novel therapy for a while. It's not so novel there, but what are we using for these blocks? What type of medication? Because is it bupivacaine, ropivacaine, and then new generation?
And what mixes of those? Yeah. What are we adding to it?
Right. That was an interesting adventure in and of itself. So we began to explore these new blocks and these new spaces, and we put in our usual local anesthetics. And the patients felt great in the PACU, but those ropivacaine blocks and bupivacaine blocks seemed to only last for about 18 or 24 hours maximum. So you kind of lost the effect. And of course, there's different ways to extend that duration. We've used catheters in those spaces. We use other adjuvants like dexamethasone and dexmedetomidine and those sorts of things, but with varied success. There's some novel, as you pointed out, we've been using these for a couple of years now, some longer acting local anesthetics like liposomal bupivacaine. And there's another one on the market now that's in a polymer matrix that releases slowly. And so that's pretty exciting that we have the ability to put a local in a place and then it just slow releases over time, and you don't have to deal with a catheter or those other hassle issues.
Yeah, so the polymer-based one, I actually find this very interesting, is not necessarily, if I am remembering this correctly, an injection, but more of a topical. Is that correct? Like you kind of infuse it into the plane, but or not like topically into the incision site or whatever the site is. Correct?
That's right. It's got a viscous kind of feel to it. So you just sort of layer it into the wound and it sort of extrudes the bupivacaine from there.
Well, tell us a little bit more about the liposomal encased bupivacaine as well, just how that works. And I think it's something that we understand, but just to kind of stick a pin in that for a second.
The liposomal product is bupivacaine, and it's just encapsulated in this multivesicular liposome and cholesterol matrix. So when it gets injected into the body, it slowly breaks down and releases a little payload to bupivacaine over 72 to 96 hours. So you get a very predictable release of that bupivacaine at the place you put it, which is exciting because then, we can, again, extend that duration of the analgesia for days and days.
So the initial studies on liposomal bupivacaine were very limited, right? Very specialized usage. And over the years, it's expanded out a little bit more. What is the literature supporting? What types of surgeries is it, good in? What does the literature support if we're going to argue to use it in our system? That's
a great question. And to be honest, there's been a lot of controversy about this medication. A part of it stems from a relative lack of really good studies. And so when we look at the literature, it seems like it does a great job in two different areas. So one is infiltration. So surgeons putting it in the wound. And there's good data now about sort of various models in that setting. I'm more interested as an anesthesiologist in putting it in nerve blocks and fascial plane blocks. And so Where we're seeing great results and where the evidence seems to support it well is interscalene block for shoulder surgery. And then a lot of the other fascial plane blocks, erector spinae plane for thoracic surgery, for spine surgery, we're seeing great outcomes there in a lot of the studies in terms of decreasing opioids, pain, length of stay, and increasing satisfaction. Tap block is a good one too. For things like cesarean delivery, there's some good evidence now looking at things like a 50% reduction in opioids in the first 48 hours after cesarean delivery, which is an incredibly important outcome for a brand new mom who's trying to take care of her infant. So those fascial plane applications are really exciting, and we're beginning to see more and more and more of those studies come out positive and looking favorable.
We tap block all of our postpartum C-sections in several of our facilities, and with just plain bupivacaine. And it does work well, but I would love to be able to give those new moms a lot, longer duration of relief with something like liposomal bupivacaine.
Yeah, absolutely.
Yeah. We have a question. So liposomal bupivacaine is eye-wateringly expensive. Cheap trials versus cheap plain bupivacaine are equivocal. Should we stick to plain and get it in the right place?
Yeah, that's a good question and an interesting comment. I think that you do have to consider the relative value of all these therapies when you're going to make these clinical decisions. Certainly, there are places where it works well, really, really well, and we use it consistently in our service. And there's places where you could choose another therapy. And I think going back to something like bupivacaine plus or minus dexamethasone and dexmedetomidine makes sense in those settings. But I will tell you, the ability to get a patient out the door and remain pain-free after a laparotomy, having done an abdominal plane block, or have a completely numb chest after an ESP block for a mastectomy for 3 days, which is what we're seeing, is pretty impressive. The question speaks to our absence of great studies. It's incumbent on all of us and to try to do those studies to get that data out there, because we're seeing it anecdotally in our practice.
Mm-hmm. Yeah, you hear it all the time, and people. There are people on both sides, but you hear the people that love it, they love it, and it's because the extension of that. Jeff, do you think that there's any difference in technique, and then maybe some of the studies is, the learning curve of doing some of these new blocks? I mean, technically a fascial block is a little bit easier than some of the traditional nerve blocks, but I mean, what are your thoughts on that?
Absolutely. I think that's a really insightful comment and question. Local anesthetics are fairly forgiving in a fascial plane block, plain local anesthetics, because they cross fascial barriers. So if you're doing a tap block and you're one layer away, it'll probably work okay. The issue we have to face with something like a liposomal encapsulated local anesthetic is it stays where you put it. So if you are that one fascial layer away, and now all your little bupivacaine packets are releasing a fascial layer away, you might not get the results you expect. So we've learned that technique really, really counts and precision counts. And so that's a lesson we've learned with trial and error over the last few years when using this drug. And reflecting on our failures.
One more question here. It looks like liposomal bupivacaine has different approved uses in Europe. And how is this so? How does it different than in the U.S.?
As I understand it, it is approved for surgical infiltration, interscaling and fascial plane blocks in the U.S., and then the additional indication of femoral nerve block in the U.K. and perhaps Europe, which is interesting. I think that, to my way of thinking, it's a local anesthetic. The safety profile of that drug is incredibly safe drug. And if you apply it in the brachial plexus and it's safe there, it should be safe everywhere. And so it's not surprising that we've seen case reports and other instances of it being used all over the body with a very good safety record. So I expect to see some good things out of Europe and the UK with the additional indication.
Talk to us a little bit about local anesthetic system toxicity. What I'm hearing, there is some delayed onset of that. Is that something that you see with liposomal bupivacaine?
It was a real concern when I first started to pick up this vial and say, gosh, man, 266 milligrams of bupivacaine, I'm going to put that in one patient all at one time. And I'm being asked to admix that with some additional bupivacaine. So that was a concern. But looking at the pharmacokinetics of how it behaves in human beings, and now I think we're up to having 8 million doses have been used, or something to that effect. So there's a lot of good data on both its clinical safety and we have the PK data. The good thing is it stays encapsulated like it should. And so that plasma concentration curve is very, very low and slow. It peaks at about 36 hours. And the peak plasma concentration of that 266 in an adult seems to be somewhere in the neighborhood of 300 to 400 nanograms per mil. So the lower limit of toxicity to cause last is about 2,000 for bupivacaine. So even with a full 266 dose all at once, the most you should get is less than 500 nanograms per mil. That helped me sleep at night to see that PK data and understand that, okay, I'm not going to potentially put someone in harm's way by giving a dose and sending them home.
I think that's everyone's worst fear,
Yeah.
something like that could happen.
Yeah, definitely.
Absolutely. Yeah.
We actually have two more questions. One of them is for me, and one of them is for Jeff. So I'm going to ask the one for Jeff first. So the question is, we're already being warned off femoral nerve blocks because of falls, potential for falls. Won't the liposomal bupivacaine make this worse?
We have to use our clinical judgment in applying any of these medications to our patients. I agree. We don't do as many femoral nerve blocks anymore as we used to for those reasons.
Right. Yeah, exactly.
Yeah. Our total knee. So we go a little bit further down the thigh and do a Dr. Canal block, for example, for our total knee. And I think that's the kind of decision making that will be important in terms of prioritizing your outcomes and your goals. Motor sparing nerve blocks, for example.
Yeah. Well, before we get to Mark's, we'll ask it next, and then we'll bring everybody back. But Jeff, in the last little couple minutes here, talk to us about what this actually looks like when you're using it on a patient. What should you expect? What do you see? Level of comfort for them, as soon as they get the block, or is it delayed? How does it work?
Yeah, that's a good question. So one of the ways we failed early on was by not adding some additional bupivacaine in there, because it is a slow release medication. And so we gave it, neat, as it were. And the patient kind of woke up at the end of surgery and said, hey, I don't feel any different. And it took some hours. So we have learned to mix a little bit of extra pre-bupivacaine in there, and that sets most of these fascial plane blocks or the interscaling block up nicely, and then the slow release stuff takes over and carries them through the rest of that 48 to 72 hours. We have seen that we do get some motor block initially with the added bupivacaine, but that goes away before that 24 hours. And then the liposomal bupivacaine seems to just release a slow gradient so that you get a nice sensory block or an even analgesic block, but without the motor. And then that eventually tails off after about 48 to 72 hours.
Well, that's great, Jeff. Thank you so much for joining us. As we bring up the other panelists, Vicki, I'm going to ask you this question from Mark Koch. If you give Duromorph in the spinal epidural, is the goal to improve the quality of analgesia, duration of anesthesia, or both?
Yeah, and there was actually a follow-up question by Mark as well, asking about then the tap block. And so this is, kind of a controversial thing. A lot of the literature out there is back and forth. If you're doing epidural analgesia and you're using Duromorph or fentanyl in the epidural, there's really no benefit of having a tap block because the epidural lasts, it has a duration on it. And so my short answer is both. I would like to see tap blocks be given and epidurals without Duromorph, but I know that's not well favored by a lot of anesthesiologists in my group anyway. But we do use Duromorph. We do in the spinal epidural or in the spinal, and then we do tap block, and our data proves that has shown great benefit, and we've had a huge reduction in opioid usage and decreased length of stay, lower pain scores, all of that. So I think it's for analgesia and for duration of that spinal, and then once that spinal starts to wear off, usually for us it's about 6 hours, then they have the benefit of the tap block.
Thank you, gentlemen, for joining us. In the last couple of minutes, does anybody have questions for each other? I know you guys have heard each one of these conversations, and I was just curious to see what you all were thinking.
My question was about the liposomal bupivacaine. I get the impression from this side of the Atlantic there's been a lot of aggressive litigation and a lot of controversy about the approvals. Has all that kind of blown over now? Everybody's figured out what they can do without having a fight about it?
That's a good question. I think to a certain extent, Rob, it's still There's, as I said, it's still some controversy about this drug that is not helped by the absence of like amazing, fantastic trials. So we still need those to push this forward. Either way, we just need the answer. So what's interesting about it is that's one sort of lens and one voice in our ear. And on the other side, we hear from so many centers who are using it. Oh yeah, we use it every day and it's amazing. It's working well for us, or else they wouldn't use it. As it was pointed out, it's not cheap. I mean, it's not pennies. So if someone's paying whatever, the price is for it, it must have some value. So I think we're getting closer to that reconciliation between the evidence and the clinical appreciation of it. But I think we're not quite there.
Well, gentlemen, we have run out of time. We really appreciate you taking the time to have this conversation. To move the needle, we need to have conversations about novel therapies, and we need to accept the fact that we all have to come and look at the literature and look at ways, that we kind of, again, move the needle. So thank you for what you do out in practice, and thank you for the conversation.
Thank you all so much. It was a great conversation.
Top Bed Talk.
EBPOM USA is coming up July 15th. Check us out at ebpom.org. We're going to have amazing conversations with key opinion leaders from around the U.S. about everything perioperative medicine. Again, check us out at ebpom.org.